Assalamu alaikum everyone. Today we'll discuss about hemolytic uremic syndrome, which is a type of thrombotic microangiopathy usually occur in children. So it's mainly occur in children less than 5 years of age. What is the underlying etiology? So bacterial exotoxin. So we have Shiga-like toxin known as virotoxin, which is produced by E. coli, enterohemorrhagic E. coli, and its strain O157 ratio H7, usually transmitted via contaminated foods. And another we have Shiga toxin is produced by Shigella dysentery, while Shiga-like toxin is produced by E. coli. Then we have strep pneumo infection, which also account for some infection, but it's rare. And atypical hemolytic uremic syndrome is complement dysregulation, which is hereditary or acquired and accounts for approximately 5% of the cases with non-infectious etiologies, referred to as atypical hemolytic uremic syndrome. So about 15% of children infected with E. coli will go on to develop hemolytic uremic syndrome. So underlying pathogenesis, hemolytic uremic syndrome is a thrombotic microangiopathy condition characterized by the formation of microthrombi, including the microvasculature. Other main microangiopathies are thrombotic thrombocytopenia purpura. So we have hemolytic uremic syndrome and thrombotic thrombocytopenia purpura, which form thrombotic microangiopathies. The two conditions have same pathophysiology and clinical finding is common, but different etiologies are present. Hemolytic uremic syndrome is caused by bacteria toxin E. coli or another organism. Leads to mucosal inflammation and facilitate bacterial toxin entering the systemic circulation. Toxin cause endothelial stem damage, especially in glomerulus. So renal system is affected. Shiga-like toxin binds GB3, a glycolipid receptor molecule predominantly located in the renal and interstitial endothelial cell, result in cellular injury. Damaged endothelial secrete cytokine, promote vasoconstriction and platelet microthrombi formation at the site of damage, leads to intravascular coagulopathy, thrombocytopenia due to consumption of the platelets. RBC are mechanically destroyed as they pass through the platelet microthrombi, including small vessels like arterioles and capillaries, leading to hemolysis forming schistocytes on the smears and end organ ischemia and damage, especially in the kidney. So there will be decreased GFR. E. coli infection, Shiga-like toxin in systemic circulation, so toxin-mediated endothelial injury, microthrombi formation, blockage of small vessels, RBC fragmentation or hemolysis and end organ damage. Then we have clinical features, so remember that there will be a diarrheal illness, usually bloody diarrhea. For the past 5 to 10 days precedes the onset of hemolytic uremic syndrome symptoms in many children. So remember that there will be bloody diarrhea in the children preceding the symptom of hemolytic uremic syndrome. And a triad of clinical findings occurs in hemolytic uremic syndrome. So remember HUNT instead of HUS as a mnemonic to remember the clinical features. So by HUT you can remember from H you have hemolytic anemia, from U you have uremia, which is renal dysfunction or acute kidney injury, and then you have from the T you have thrombocytopenia. So these three are the clinical features of the patient presenting with hemolytic uremic syndrome, which is known as triad of the hemolytic uremic syndrome. So we will have thrombocytopenia presenting with petechiae, purpura, mucosal bleeding, prolonged bleeding after minor cuts. Then we have hemolytic anemia, so it will present with fatigue, dyspnea, pallor, and jaundice, and impaired renal function like hematuria, proteinuria, oliguria, and urea. So these are the clinical features of this disease. Remember, the typical syndrome will present in a patient who will be a preschooler and who will have a diarrheal illness for the first 5 to 10 days and present with petechiae, jaundice, and oliguria, and the diarrhea usually bloody diarrhea. Then how to diagnose? So now about diagnosis. On lab finding hemolytic markers, you will have decreased hemoglobin, decreased heptoglobin, increased indirect bilirubin, increased retic count, increased LDH, and there will be increased schistocyte on the smear. Then in coagulation profile, you will have decreased platelet counts, and the PT, APTT, and the D dimers and fibrin degradation products. D2 will be normal or slightly elevated, as in contrast to DIC, where they are highly elevated. There will be increased WBC count and the Coombs test will be negative because it is non-immune mediated hemolytic anemia will be present due to mechanical destruction of the RBC. On serum chemistry, there will be increased burn and crit due to impaired renal function, and urinalysis will show hematuria and proteinuria. Now we have different type of differentials of the hemolytic uremic syndrome. Like in hemolytic uremic syndrome, we have discussed that endothelial cell dysfunction occur due to bacterial toxin, and the presenting patient is usually toddler or preschooler with history of diarrheal illness preceding the symptom of hemolytic uremic syndrome, and present with petechiae, jaundice, and oliguria. Smear there will be schistocyte and decreased platelet counts, PTINR, APTT, D-dimer, fibrin degradation product. They are normal or slightly increased. Then in thrombotic thrombocytopenia purpura, we have an enzyme deficiency known as ADAM-TS13 deficiency, and the presentation will be a previously healthy adult, sometime associated with triggers like infection, surgery, or pregnancy, and the patient will present with mental status changes like fever and fever. These two are the additional findings with hemolytic uremic syndrome triad giving a pentad. So mental status changes and fever will be present along with the finding of the hemolytic uremic syndrome in thrombotic thrombocytopenia purpura. There will be schistocyte and decreased platelet count, and these will be not affected in thrombotic thrombocytopenia purpura. Then we have DIC. So in disseminated intravascular coagulation, we have systemic coagulation activation leading to platelet and coagulation factor consumption. So it's a mixed disorder. Patient with a history of serious underlying illness like sepsis, trauma, malignancy, present with thrombosis, embolism, organ dysfunction, and are bleeding, and there can be presence of schistocyte, and the platelet count will be decreased, and the PT, APTT, D-dimer, and fibrin degradation product. These all will be elevated in case of DIC. Another differential is ITP. So remember that in ITP we have antiplatelet antibodies against GP2B/3A receptor. It can be asymptomatic or present with petechiae, purpura, epistaxis, heavy menstrual bleeding, and gum bleedings. And there will be normal platelet morphology. So morphology is not affected, and platelet count will be decreased, and all other finding will be normal in case of ITP. Only bleeding time will be increased. Then we have Bernard-Solier syndrome. So in Bernard-Solier, we have this is adhesion disorder in which we have deficient GP1B/9 receptor and its autosomal recessive. While Glanzmann thrombasthenia is aggregation disorder, we will have deficient platelets GP2B/3A receptor and it's also autosomal recessive. So it's aggregation disorder, while Bernard-Solier is adhesion disorder, and different receptors are affected, but both are autosomal recessive. On finding, we will have giant platelets in Bernard and decreased platelet count, and remember abnormal ristocytin cofactor assay. Normally ristocytin promotes the adhesion of the platelets, but here we have the receptors are affected, so the adhesion of the platelet is also impaired. So abnormal assay will be there. In Glanzmann, we have normal platelets and abnormal results on platelets aggregation test, confirming the diagnosis. So abnormal cofactor assay will be there, and other findings are not affected in these both conditions. So these are the different types of differential diagnosis of hemolytic. Other platelet disorder like von Willebrand disease and acquired disorder like drugs, aspirin, NSAIDs, uremia, and paraproteins. Treatment: so avoid antibiotics and anti-motility agent. They increase the likelihood of hemolytic uremic syndrome in suspected infection with E. coli. Monitor and correct fluid, electrolytes, acid-base disorders, BP and RBC transfusion is given in case of severe anemia. Anti-epileptic drugs like diazepam, phenytoin in case with seizures. Dialysis can be indicated. Up to 50% of patients of hemolytic uremic syndrome usually require dialysis. Plasma exchange therapy only in the refractory. Eculizumab is effective for the treatment of atypical hemolytic uremic syndrome. It is an anti-C5 which work against the complement, and atypical is caused by the complement. So eculizumab is effective for the treatment, as well as it's given in paroxysmal nocturnal hemoglobinuria, which is also complement mediated. may be beneficial in HUS with neurologic symptoms. Post-diarrhea HUS is a notifiable condition nationally. Platelet transfusion should be administered with caution unless patients are bleeding or require an invasive procedure. Some studies suggest they can exacerbate microangiopathy. And these are different types of complications like CNS, GI tract, heart is affected, pancreas is affected, liver and kidney. Prognosis would depend primarily on the prompt initiation of the treatment. Timely treatment prevent complications like AKI, coma and death as well as progression to chronic condition. Long-term renal sequelae occur in 35 to 55% of patients. Atypical has less favorable prognosis and higher risk of progression to end-stage renal disease. So that's all about hemolytic uremic syndrome.